One like now I call upon Dr. Tejal. Now the topic is management of the PCR. Over to you, madam.
Okay, now that they've discussed about making, phaco easy by management of a soft cataract, hard cataract, and you still have a PCR, how do you manage that is something that I'll be dealing with today. The first important thing is how do you recognize that there is a rent? There are simple things that, the eye gives away itself, like a pupil snap sign. The AC can deepen suddenly. There can be striae on your posterior capsule, or the red reflex suddenly becomes even more clear. The nucleus, which was freely mobile, becomes difficult. You can see the lens tilting or also vitreous in AC. So these are the signs that, there is PCR in the eye. So what are the important steps? So if you start with the wound construction itself, make sure that the wound is always a clear square shape. And it is not too peripheral. So if there is peripheral, the sealing itself becomes difficult, and that itself can cause difficulty in managing every step of your phacoemulsification. And in rhexis, I think Dr. Venkatesh has covered the whole rhexis part of it. But usually, say, in an intumescent cataract, it's always better to use a microrhexis forceps to make sure, you complete your rhexis and you do not have an Argentinian sign. Use generous amount of viscoelastics. During hydrodissection, again, if you put a lot of pressure in the eye or you try to overfill the anterior chamber, say there is already a lot of viscoelastic and you try to inject more of hydro, you know that, there is going to be a lot of pressure and the PC is going to open up. The sign is your iris starts to pop up or there's a pupil snap sign again. So make sure you remove the viscoelastic and then inject fluid in the eye. And again, this is for cortex aspiration. So always when you're doing IA, we always feel, okay, now the nucleus part is over, so nothing can go wrong. But when you're using your aspiration port, if your aspiration port is facing towards your posterior capsule, there are more chances that you might catch your posterior capsule and that itself can cause a rent. So make sure the aspiration port is facing superiorly so that it's easier to clear off the cortex and you don't put any pressure on your posterior capsule. And it's always better you inject the IOL under irrigation, or for a beginner, it's always better to put a viscoelastic. Now PCR has occurred. What do we do next? So you always check if there is a vitreous loss or there is no vitreous loss. So how do you say that? There is irregularity in the anterior chamber depth. The nucleus, which was freely mobile, suddenly becomes difficult. The pupil is irregular, or you can see rolled up margins on the posterior capsule itself. So how do you identify this? So what do we usually say is you can always inject triamcinolone to see if there is vitreous in the AC or if there is no vitreous. So during these cases, make sure you stop your phacoemulsification, you inject visco, and then you remove your phacoprobe. That the natural tendency is the minute you get to know that there is a PCR, you remove your phacoprobe. That's the worst thing that I can do to the eye. I want to make sure that, my eye is nicely formed. You put the viscoelastic and then you make sure you remove your phacoprobe so that the PCR doesn't extend further. So you always put, for a beginner or even for a senior surgeon, it's always better to put triamcinolone to see if there is vitreous in the AC and then proceed. And if there's a large chunk, you know that it's going to be difficult, please do not fetch it. You always, if you feel it's tilting, you hand it over to a VR surgeon or you convert to SICS and you remove the chunk. So if there is no vitreous loss, as I said, you remove your phacoprobe after putting visco in the eye, and then you can do a vitrectomy accordingly. So how do you this is a case of, so this was an open PC already. This is a PPC case. So you do not put a lot of pressure in the eye. You make sure if you see, we are putting visco just before removing the phaco handpiece. You put visco, you make sure that open PC does not extend. This is more like a PCC. So PCC is good for the patient because you don't have to YAG it later. So you make sure it stays that way and then you put IOL in the bag. So now there is PCR. how do you go ahead with vitrectomy? These are the pearls for your anterior vitrectomy. So it's always better to use a AC maintainer. So these are the settings what we usually use. And always do not pull out when you're in vacuum. That's one of the most important steps, where you're on vacuum, but you're pulling the vitreous, which is causing a lot of traction. So make sure you do not pull your vitreous in vacuum. These are the settings of vitrectomy that we use. And these are the different modes of vitrectomy, that is IA cut, the cut IA mode, and the vitrectomy mode. And as I said, if it is a small piece, central opening, make sure you convert it. If it's a linear tag also, you can convert it to a PCCC to make sure that you can still place lens in the bag and it is going to be stable. So this is only if the PCR is away from the equator. So, and doing a controlled PCC will only strengthen the PC, and it is not going to give way to a further thing. So which IOL to choose? This is again a very tricky thing that, it's left to each surgeon. But again, if it is a small PCR with a PCC, a single piece IOL in the bag stays very well. So if multi-piece IOL in the sulcus works well, if it is an intact bag, small PCR, and there is no vitreous loss. If it is a larger PCR with an intact CCC, you can put a 3-piece in the sulcus with an optic capture. And if you feel the support is not good enough, always go ahead with an SF IOL or an iris fixated IOL. And if it's a dropped nucleus, IOL in the sulcus, and refer to a VR surgeon. So how do you again calculate the lens? Now this is again difficult because the optic of the lens is shifting towards the cornea when you're going to place it in the sulcus. So this is how we calculate the power usually, which is at the capsular bag, and how much do you subtract it from the bag to get the ideal IOL. So post-op care again is very important. It's always good to explain to the patient, say we are putting lens in the sulcus. It's always good to tell the patient that there was a complication during surgery. The lens is not placed in the bag, the lens is placed in the sulcus. If it's important for the patient to know. If a patient goes to another hospital and then you have not told the patient always comes back and always questions you that, why was I not informed? So it's always important to counsel these patients, take a little more extra chair time to tell them that this is what had happened. Control inflammation with steroids and topical and systemic, frequent follow-up. If you're calling your patient, say 1 month after surgery, it's always important, if there's a PCR, call them a little more frequently so that, you can have a closer lookout at the complications. So again, what are the post-op complications which commonly happen with the PCR are again striatic keratopathy, corneal edema, because you're going to use a lot of more power. That there is stress during when there's a PCR that happens in the eye. So the way we react and handle the tissue is also going to be different. So there can be a subtle post-operative complications with PCR itself. So to summarize, it is very important to assess the patient, like your PPC and all. We know that it is going to open up, so you take steps accordingly. In case of pre-existing PCR, you can always do an anterior segment OCT. So anterior segment OCT is very good in cases of posterior polar cataract or an intermittent cataract where you do not know the status of your PC. So when you do an AIOS-OCT, you know if your PC is intact or if it's opened up. So you can prepare accordingly. Proper wound construction, staining, all these play a very important role. Early indication, like I mentioned, like the deepening of the AC, the pupil snap sign, these all are takeaway that the eye gives when there's a PCR. And again, to prevent collapse of the anterior chamber, make sure we inject the OVD first and then remove the probe. Triamcinolone for everybody who has a PCR so that you know there is vitreous or there's no vitreous in the eye. Bimanual anterior vitrectomy is very important. It's always better to do it that way. Cortical removal at very low flow. Make sure the flow is low and then we do it away from the PCR, wherever the opening is. And the choice of the IOL again depends on the size of the PCR and the vitreous loss. So again, post-op care in the form of counseling and all is very, very important to the patient. So we at NN are hosting our annual Cataract and Refractive Conference. It is called the His Master's Voice, which is from July 18th to 20th. I would like to invite all of you. You can take a picture of the QR code or scan it, and just looking forward to seeing you all in Bangalore. Thank you, everyone.